of the disease. Bone disease occurs in 80 to 90% of myeloma patients. And these patients can come with what you call cord-Icoana syndrome. So you guys might have read about this in your neurology lessons, cord-Icoana, where we have got a pressure at the cord-Icoana, which are the lower nerve roots. And the patient will present with constipation, with retention of urine, and loss of power. And that is an emergency. So cord compression is an emergency. If you have a patient who comes with a certain neurological deficit, you must rule out myeloma. Do paraprotein, look at the albumin, look at the globulin, look at the total protein, and see whether the patient could have a myeloma. And what you do, you basically urgently either give radiotherapy or start to give steroids so that the pressure is reduced and you can save a long-standing neurological deficit in these patients. And there you see the MRI. As you can see that there is a mass. Can you see this globular mass sitting there in your lumbar vertebra? So this is a myeloma collection, myeloma cell collection, which is pressing onto the spinal cord. Yeah. So this is an emergency. And how do you manage? As I said, patient needs urgent radiotherapy. They might also need a surgery if there is a bony fragment which is broken and pressing onto the nerves. So in that case, we need the surgery, or you need the treatment to start for myeloma like steroids. A couple of words about hyperviscosity, because myeloma, if they have got very high paraprotein, like 80 to 90, and especially if they're IgA, they are large molecules which can cause the problem with hyperviscosity. It's a large molecule. So you should always be worried about when the patient has got IgA myeloma as compared to IgG myeloma. Okay, so patients can have present with end organ dysfunction, kidney disease. They can have neurological deficits and many other things. So hyperviscosity syndrome does not only occur in myeloma, it can happen in other conditions also. Well, it can happen in myeloid leukemias where the white cell count is so high. It can happen in acute leukemias, acute ALL. It can happen in polycythemia rubra vera. It can happen in Waldenström macroglobulinemia. So it can happen in a host of conditions. Yeah. So you might get a question about hyperviscosity syndrome. And the treatment, of course, is hydration is the first thing. And second thing about the rasburicase or allopurinol, and also about starting the treatment. Yeah. Clinical features, you may have bleeding, you may have cerebral symptoms like headache, blurring of vision, you may have bleeding in the brain or an infarct. You may have pulmonary embolism, shortness of breath. You can have vision problems, and things like in myeloma. You can also do plasmapheresis, but that is becoming more and more obsolete these days. You tend to treat the condition rather than doing the plasmapheresis. This is again about a cartoon of treatment. As I said, the treatment has really come of age in hematological malignancies. In olden days, we used to in 1960s we had only Melphalan and steroids, just 2 drugs in 1960, and now you talk about 2022, where we have got at least 10 or even more drugs to control and treat myeloma, but still no cure. Yeah. And now we are actually having different class of drugs for myeloma. Like we have immunomodulatory drugs. We have got anti-CD38 monoclonal antibodies. We have got proteasome inhibitors like ixazomib or bortezomib or carfilzomib. So there are many drugs which you might read in your pharmacology lessons. So autologous transplant is actually one of the standard of care for myeloma in the current scenario, where the patient is younger than 70 years. So what you do autologous transplant. The patient has gone into remission, and what do? You take their own cells, the stem cells, you give them chemotherapy and put the stem cells back into them, and then they grow a fresh bone marrow. So as you can see here, that you collect the cells and then processing and then cryopreservation and then reinfuse after giving chemotherapy. But chemotherapy has to be given so that we can wipe out the whole bone marrow. So general side effects of chemotherapy, you can have nausea, vomiting, hair loss, myelosuppression, neutropenic sepsis, GI upset, diarrhea, because mucosal roughening is there, mucosal destruction is there. You can have lethargy, malaise, infertility, secondary cancers after many years. And few drugs like anthracyclines can cause cardiomyopathy. Nerve damage happens because of vincristine. Lung damage happens because of bleomycin, which is given in Hodgkin's disease. Steroids will have various side effects like diabetes you can have with the steroids. You can also have psychological side effect with steroids. Patients can go into depression or hypomanic stage. So neutropenic sepsis, I think it's very important to know about neutropenic sepsis because this could be a fatal complication of giving chemotherapy, right? So any temperature above 38 degrees with a neutrophil count of 0.5, that's the definition, right? It is an emergency. Patient should not sit at home. Patient should be in the hospital, and there should be what is called as a needle to and what is it called? Antibiotic to needle hour. That means how quickly we can give the antibiotics within an hour of getting the patient into the hospital. When the patient comes to the hospital with a neutropenic sepsis, within 1 hour, you must give antibiotic. Otherwise, you can lose the patient, right? They can go into the septic shock. And the treatment guidelines, the first line treatment we give is tazocin, tazobactam, along with aminoglycoside like gentamicin or teicoplanin and vancomycin. And if the patient is penicillin allergic, you can give aminoglycoside plus teicoplanin and vancomycin. And you can also give metronidazole if the patient has got diarrhea or abdominal, patient may have typhlitis where you got inflammation of the bowel. And then you can add metronidazole. And then if the patient remains in shock, you'll have to, give inotropes. Patient should go to intensive care. And, later on, especially in the myeloid leukemia, where you can have prolonged neutropenias, patient can develop fungal infection. And then you have to start the fungal treatment after the 72 hours of persistence of fever. So these are the neutropenic guidelines from NICE. Which says that the important thing is how soon you give the antibiotic. As you can see that the total deaths from neutropenic sepsis, this is England, the whole data from 2001 to 2010, and neutropenic deaths have increased because more chemotherapies are being given primarily. But neutropenic sepsis is a very important complication. You must remember this, and it will be an MCQ. Late effects of chemotherapy, you can have secondary malignancies, cardiac disease, endocrine dysfunctions, psychological trauma, lung damage, infertility. These are long-term side effects of chemotherapy and radiotherapy. And you can have, of course, secondary malignancy, especially in the breast cancer. If you give radiation to the chest area during Hodgkin's lymphoma, especially to a female, they can develop breast malignancies. In conclusion, the malignancies, either myeloid and lymphoid, they have a wide range of malignancy arising from hematopoietic stem cells. They're classified by the cell of lineage, degree of cell maturation, acute versus chronic, high grade versus low grade. You can have genetic alteration defining a number of entities. Treatment includes radiotherapy, therapeutic antibodies, targeted treatment, and prognosis varies depending on their genetic abnormalities, depending on the disease, whether it's a low grade, high grade. And so that is also quite, there's a quite wide variation in the prognosis as well. But generally, the prognosis is getting better with every passing year because we are getting new drugs. We are unraveling various kind of the cell pathways, and we are blocking those pathways so that the maturation doesn't happen and the cell is especially killed or destroyed. So that was the end of my presentation of